we are directly going to the topic. Dr. Charmaine Solomon, our Associate Professor, Government Medical College, Calicut, will be talking on the topic of advances in investigative techniques in uveitis. Over to Charmaine.
Good afternoon. So what is new in uveitis? There are lots of investigations that have made the life of the ophthalmologist easier. And now we hear the term multimodal imaging, which is we collect images from various modalities, various machines, and which help us to understand the disease as well as monitor response and treatment. So we have color fundus photography, multicolor imaging, fundus autofluorescence, fundus fluorescein angiography, indocyanine green angiography, and the non-invasive optical coherence tomography and OCT angiography. So in color fundus photography, we have these machines since long. The conventional cameras give us 50 to 55 degree view of the retina, while the wide field images cover 60 to 100 degrees of retina. The newer ultra wide field give us up to 82% of the retina we can visualize with a single click. And these machines are good because it can even give us these images in a non-mydriatic pupil. That is, especially if there are synechia and the pupil is not dilating in posterior uveitis, they are helpful. And it also helps in documentation of the disease at presentation and to explain the disease to the patient. They can see for themselves what is happening in their eye and their response to the treatment. So next is multicolor imaging, which uses confocal scanning technology. It uses 3 lasers instead of single white light, and the 3 layers give us information from the different layers of the retina. The blue laser gives us information from the vitreomacular interface and the inner retinal layers, the green from the middle retinal layers, and the red from the outer retina and choroid. So the benefit is that it gives us higher contrast and more detailed images. It is less affected by media opacities and again in non-mydriatic. Then we have fundus fluorescein angiography, which is helpful. In most cases of uveitis, we have early hypofluorescence to late hyperfluorescence. And fundus fluorescein angiography now helps us, especially in cases of occlusive vasculitis, where you need to look at the peripheral for capillary non-perfusion areas, and of course macular ischemia. CNP areas, it is helpful to delineate, and targeted photocoagulation can be carried out. If there is disc leakage, you know that the disc optic nerve head is also inflamed, and NVD, NVE, all this can be well delineated with the FFA. Then coming to indocyanine green angiography, it has helped us to divide the uveitic entities into primary inflammatory choriocapillariopathy and secondary inflammatory choriocapillariopathy, as well as stromal inflammatory vasculopathy. And then we have fundus autofluorescence, which is coming up in a big way. There are lots of studies which help us explain the pathophysiology of the uveitic entities. So basically this is mapping of the lipofusion in the retina. Again uses confocal SLO technology, and it is a measure of the RPE photoreceptor status. Then we have optical coherence tomography and also angiography. It's a non-invasive objective tool for documentation and follow-up response to treatment. You can assess the complications, especially with the OCT, the macular edema, macular atrophy, the epiretinal membrane, and CNVM. And there are also studies which grade intraocular inflammation in the anterior segment with the SSOCT. Then you have OCT angiography, which helps us to look into detail of pathophysiologic mechanism of various uveitic entities and monitor response to treatment. It is also very sensitive to diagnose type 1 and type 2 CNVM. Then if the lesions are retinal and in the posterior pole, we can always start off with an OCT. And in the periphery, you can use ultra wide field imaging, and some machines also have ultra wide field OCT with them. Associated vascular pathology is present, go for an FFA. On follow-up, OCT angiography or FFA will help you. Choroidal lesions, the first would be the fundus autofluorescence, which will help you to differentiate between the entities and also in treatment and follow-up. Then to confirm the condition, you can do an ICG angiography. So coming to retinitis lesions, first we have the commonest of them all, that is the toxoplasmosis. Imaging can help in monitoring the response to treatment and help you to decide when to stop treatment, especially when they are on anti-toxoplasmic drugs and steroids. You need to know when to exactly stop treatment. So this is a very objective method. On the OCT in the acute stage, you can have vitreous cells, posterior hyaloid thickening, and deposits on the retinal surface with mirror image deposits on the hyaloid. There is full thickness retinal involvement. The green, that is a full thickness retinal involvement there. And in contrast to viral retinitis, you can see that there is a focal choroidal thickening. The blue oval is the focal choroidal thickening below the retinitis patch. So on resolution, first you get a resolution of the vitritis, and then the retinal edema and the choroidal thickening goes down. Then on the OCT angiography, you can detect CNVM if it develops in the chronic stage. Then we have the viral retinitis. In the viral retinitis, you have again necrotizing full thickness retinitis, but in this the difference is that the sparing of the RPE and choroid in contrast to toxo. And CMV retinitis, the vitritis will be less. There are two patterns that have been described, the full thickness pattern and cavernous pattern on OCT. These cavernous areas may later go in for retinal thinning, breaks and rhegmatogenous detachment. Then coming to FAF in viral retinitis, the active lesions at the arrow, they show the active edge which is hyperfluorescent in contrast to the ischemic necrotic area, and this is a indicator of progression of the disease. If this moves posteriorly, you know that the patient is not responding to your treatment. It helps in defining the disease process and to monitor response to treatment. So this is another case where an 8-year-old presented with a loss of vision for 1 week. The only positive history she had was that of parotid enlargement with fever 2 weeks prior to this lesion, to the issue. So on examination, her vision was CF with sluggish pupil bilaterally, and with the classical presentation, we diagnosed progressive outer retinal necrosis. In that you have outer retinal edema and thickening, which later involves the full thickness retina and goes in for retinal atrophy soon. So this was a 40-year-old male who complains of blurring of vision with history of fever without rash 3 weeks prior, and the best corrected acuity was 5/60. He was evaluated elsewhere. IgG toxo came positive, IgG CMV came positive. Now what do we do? So here you can see that there are multiple retinitis lesions. There is a associated vasculitis. So in also the patient being from an area endemic for typhus, we went in for the Wheel Felix test and it was positive. The patient was started on doxycycline and steroids, and his vision improved to 6/12 within 10 days. So this is the initial OCT. You can see the full thickness retinitis lesion, the hyporeflective space suggestive of macular edema, and the inflammatory cells within the retina. So with the doxycycline and steroids, the patient improved very well. So OCT angiography in rickettsial retinitis, it is helpful for visual prognosis because there will be capillary dropout areas on the superficial capillary plexus and the deep plexus. Enlargement of the FAZ, if it is seen, it is a definite indicator that the patient's vision is not going to return to normal. And there may be flow void areas, or it may even be projection artifacts on the choriocapillary slab, but this usually recovers. Then coming to dengue, 3 types of involvement have been described on the OCT as diffuse retinal thickening, cystoid macular edema, and thickening and increased reflectivity in the subfoveal outer retinal layer suggestive of foveolitis. The Swepsos OCT, newer things have been defined like hyperreflectivity of the outer nuclear layer, the conical foveal elevation, intraretinal cystoid spaces, outer retinal thickening and disruption. The OCT angiography again shows perifoveal flow deficits more in the deep capillary plexus more than the superficial, which persists in spite of steroid therapy. And coming to a non-infectious retinitis, the Behçet's disease, the FFA can give you the classical fern leaf pattern of leakage with capillary non-perfusion areas. And on OCT, you have focal inner retinal thickening. So this is different from the other viral retinitis, where you have focal inner retinal thickening, and cystoid macular edema may be associated, and the long term you can have an epiretinal membrane or even rare cases macular atrophy. So OCT angio again shows coming to the multiple evanescent white dot syndrome. So in the white dot syndromes, the FAF will give you a clue to what is happening. So in mutes we have the hyper autofluorescent lesions here. And on ICJ, you have hypocyanisin spots which persist into the late phase. OCT shows disruption of the ellipsoid zone with and the interdigitation complex with an intact RP. Then in AP and PP, you have the larger placoid lesions here, And on OCT angiography, you have flow deficit on the choriocapillaris. These are multiple flow deficit areas here on the choriocapillaris slab. The ICGA will show you placoid hypofluorescent lesions. In the active stage on the OCT, you have outer retinal hyperreflectivity with disruption and RPE hyperreflectance and increase in the choroidal thickness. In the inactive stage, there is disappearance of the hyperreflectivity and there may be restoration, partial restoration or atrophy of the outer retinal layers with normalization of the choroidal thickness. On FAF, you have hypoautofluorescence corresponding to the outer retinal hyperreflectivity, and the inactive stage you have progressive increase in the hyperautofluorescence. So you have a mixed pattern here. In multifocal choroiditis spectrum, the FAF will give you hypoautofluorescent lesions with a hyperfluorescent halo. On ICG angiography, you can confirm it with hypocynescent lesions which persist and expand into the late phase. On OCT, you have hyperreflective material breaking through the RPE with outer retinal disruption. And in coming to serpiginous and serpiginous-like choroiditis, in the active stage, you have outer retinal hyperreflectivity, loss of the ellipsoid zone, and increase in choroidal thickness. In the heel stage, there is thinning and atrophy of the outer retina, RPE and choroid. And in this, you have hyperfluorescent lesions in the active stage. Then a thin rim of hypoautofluorescence starts surrounding the lesion. Then it comes to a mixed pattern, predominantly hypofluorescent, and this comes to uniform hypoautofluorescence when the lesion becomes inactive. Then OCT angiography in serpiginous or serpiginous-like choroiditis, there is choriocapillaris flow disruption which precedes the involvement of the outer retinal layers and RPE. And the choriocapillaris slab lesions in the active stage are larger than what is seen on the fundus autofluorescence. Lesions, it is important to look at this because if the lesions are not associated with FAF abnormalities, it is an early sensitive sign of disease activity, and if you intervene at this stage, you can prevent more damage. Then coming to choroidal stromal inflammation, in tuberculosis, the tuberculous granulomas are usually solitary, large, and they have more fluid accumulation as compared to other stromal involvement. Then you have the contact sign where the RPE, choriocapillaris and the overlying neurosensory retina show inflammatory changes. Then coming to sarcoidosis, you have multiple homogeneous hyperreflective lesions with well-defined margins and less fluid that compared to tuberculosis. In the Vogt-Koyanagi-Harada disease, on the FFA you have the starry sky pattern with late pooling, and the ICG angiography you have hypocynescent lesions suggestive of choroidal granulomas, and on the OCT angio you have multiple flow void areas on the choriocapillaris slab. On the OCT, multiple features have been described. That is, first of all, the increase in choroidal thickness and the RPE undulations. These are seen in majority of the eyes, and if you see this, this is associated with more recurrence and worse vision. Compartmentalization of fluid in the subretinal space and in the intraretinal space is characteristic, and the bacillary layer detachment, that is fluid accumulation within the photoreceptor layer, is a feature. Then you have membranous structures which are shed photoreceptor outer segments and subretinal hyperreflective dots which result from photoreceptor damage. So that is in a nutshell about the newer things. Thank you.
Thank you, Dr. Charmaine, for the beautiful explanation of newer advanced investigative modalities.